Thanks, Nikki. So I'm not from Brisbane, but I feel enough in touch with the city that I can sense that somewhere in Brisbane at the moment is a 3-year-old child with a fever, and they've only had that fever for a short time. But probably at about 11:30 tonight, that child will still have a fever, and their parents will be worried enough, so worried that they want to take that child to Lady Salento Emergency up the road. And what you're all saying at the moment is, we're worried about sepsis, but it's probably a virus. And that's what we're thinking. Why did these parents come all the way in here with this child with a fever? It's probably a virus. So when I was a paediatric registrar, I'm just reminded when I think of this, every time I think of this, I'm reminded of a conversation I had with a friend of mine, Sarah Martin, who's now a paediatric emergency physician up the road at Lady Salento, and I was exhausted. It was about 11:30. I'd seen probably my 10th child of the night with a fever that I couldn't really explain, but I was thinking it's probably a virus. I said, Sarah, why do these parents keep bringing these children in? My mum never took me to emergency when I had a fever when I was young. She just, she left me with the neighbours when she had to go to work and I had a fever. And Sarah just looked at me and said, I agree, mine too. And then she thought about it and she looked at me and she said, but Arj, maybe we're the survivors. Because it is probably a virus, and it's probably a virus until it's sepsis. And then once it's sepsis, it's really obvious that it was sepsis all along. I want to tell you another story about when I was a paediatric registrar at a non-tertiary hospital, and I was on a run of night shifts. And I was on my 4th run of night shifts, and at the start of the night shift, one of the other registrars who was handing over to me said, now Arjun, you've been doing a run of nights, you've admitted a lot of kids over these nights. I just noticed that every child on the ward at the moment is on cefotaxime. I was like, yeah, I know. We're probably overusing it. She said, yeah, I think, we've just got to think about rational antibiotic use. And I said, I couldn't agree with you more. So then at 3 o'clock in the morning, I saw a child in the emergency department who had a fever. She'd had some episode at home that had alerted the parents to go and attend to her. And she was a little bit unresponsive. They weren't sure what had happened. They brought her to emergency. By the time I got to see her as the peds reg, so I saw her straight up, she looked well enough. And I remember writing in the notes, looks well, sitting up in bed, eating an ice block. So this is the Arj Rao sign of meningococcal sepsis. So she looked well. She was sitting up in bed eating an ice block. The only thing was that she was a bit tachycardic. And I was thinking to myself, I can't start her on cefotaxime. Every child on the ward is on cefotaxime. So I'm not going to send her home. So I admitted her to the ward. I went back and looked at her again a couple of hours later, and she was still a bit tachycardic. So I said, I'm going to bite the bullet. I'm going to put a cannula in and just take some bloods, but I'm not going to start cefotaxime. So I handed her over, and then I went off for my 4 days off after nights, and I came back and, that conversation, did you hear about what happened to that child you saw with a fever? I was like, no, what happened? So they'd done the ward round. I'd handed her over. They were having their morning refreshments at 10 o'clock, which was something that was done. And the paediatrician on call got a phone call from another paediatrician who'd had a phone call from the mother who said, my child's on the ward, no one's been to see us, and she's got this rash coming up on her tummy. So she went on to develop meningococcal sepsis, and she got antibiotic treatment. She actually did fine. She got fluid resuscitated and antibiotics, was transferred to the tertiary hospital, and her outcome was good. But that, I'm constantly reminded of that because I'm a pretty calm person, but every time I say to someone it's probably a virus, I get this pang of anxiety of, until it's sepsis. So it all comes down to how common sepsis is. So sepsis, I can tell you now, sepsis is rare. And it's easy with a rare condition to convince yourself that you're really good at ruling it out. I'll say that again. So it's easy with a rare condition to convince yourself that you're really good at ruling it out. So if you talk to an intensivist, and a lot of intensivists are behind lots of research on sepsis, they'll tell you, sepsis is actually common. In this point prevalence study of paediatric intensive cares, the incidence of sepsis was 8.2%. So that should be 8.2, not 80%. So it's 8.2%, which means that a paediatric intensivist in their intensive care sees 8.2% of children with severe sepsis that have really bad outcomes. And so we can develop systems and signs. We should look at the lactate, and we should have known this. We should look at the heart rate, and all these kids with sepsis had all those signs. But what we don't know is what's the denominator. So we know that 15 to 20% of our presentations to emergency are children like that child that I talked about initially, who are children with a fever, and mostly it's a virus. So as far as we know, we can tell from studies that have been done, and the difficulty with research in sepsis is the definitions, and I'm not going to spend a lot of time on the definitions today, but we use the terms sepsis, bacteremia, serious bacterial infection, are all mixed in a lot of the research you see. But as far as we can tell, about 0.5 to 1% of children that present to emergency with fever without source will have sepsis. And in the older kids, it's actually probably closer to 0.5. So if you use your imagination really, really hard, you can imagine that looks a bit like a needle in a haystack. And that's the challenge that we're faced with, is how do we pick that needle out of the vast number of children that are coming to us with fever. And so recognition is the big challenge in sepsis. It's where all the gains can be made. So first we've got to sort of understand, what is sepsis? And I'm not going to go into a lot about the definitions of sepsis, but the way I think of it is that, there are bacteria, and the bacteria mostly coexist peacefully with babies, but every now and then the bacteria set up an unhealthy relationship with these babies, and you end up in this spiral of various things. We can use terms like SIRS, sepsis, and we go down this spiral. Many times bacteria infect children, but they don't go down this spiral, and there's probably factors related to immunity and factors related to the bacteria that impact that. And certainly vaccination is one of the biggest factors in terms of host factors that prevent us going down that pathway. So SIRS, people will have heard about, has been used a lot in terms of recognition and definitions for sepsis. So just very briefly, SIRS is really the combination of fever, tachycardia, tachypnea, and if you did a white cell count, it would be a high white cell count to define SIRS. But we know that lots of children with viral infections will have this as well. Possibly a viral infection that they, got from one of their parents who was in this room where there seemed to be lots of viruses circulating in a tightly packed group of people. But we know that the problem with SIRS is it doesn't define sepsis and it doesn't diagnose sepsis easily. And I think there's been a few studies in intensive cares of adults and children with severe sepsis where up to 1 in 8 people haven't had signs of SIRS. So that very quickly brings us on to the sort of sepsis 3 definitions and the organ failure assessment criteria, which is really more about adults than children, and there's a recognition from the authors in that paper that more work needs to be done in paediatrics. But when I read this, my big take-home message from it was this quote: "So sepsis is a broad term applied to an incompletely understood process. There are as yet no simple and unambiguous clinical criteria or biological imaging or laboratory features that uniquely identify a septic patient." So what do we do? What does a parent at home do with that child who's probably got a virus? If we're telling them, on fever fact sheets, it's probably a virus, this is what you need to look out for, when we can't even agree what sepsis is or agree how we're going to rule it out in your child. And so this leads me on to sort of this concept. So there's a few people who understand binary in the room. So I think when we see a child with fever, we either say this is a child that's going to have sepsis, or this is a child with a viral infection. And we get taught and we teach clinicians in paediatrics that, it's that gestalt, when you're senior enough, you'll have that, that gestalt, a good paediatric emergency physician just knows, they've got this feeling that that this is a well child and this is an unwell child, and I can sort of teach you about that, but it really needs to come from within, and you need to learn that. So that's a challenge, because I don't think I've got that yet, and I think what it needs to be is a conversation about what I call thresholds. So if I was to ask you in the audience, what's your threshold? And so what I mean by this is, let's say, for instance, I'm going to pick 5 to start off with. So let's say you are in front of a family with their child, and you think there is a 5% chance that that child has sepsis. How many of you will now investigate that child? Just a show of hands. So a fair few. So what about if I said to you there's a 0.5% chance that that child has sepsis? How many of you would investigate to try and get it less than 0.5%? Okay, so not very many people. So what you're saying is that 1 in 200 children that you see that you will send home without doing an investigation might progress to sepsis, and that's the threshold that you're sort of comfortable with. So if I put it that way, how many of you would be happy for 1 in 200 children that you see to go home and have a bad complication from sepsis? Yeah. So, there's no right or wrong answer to that question, but it's a question we have to ask ourselves, and we have to ask our system, and we have to ask our community. Because if we're really saying that 0% is our threshold, we're going to be investigating and managing everyone. So the other thing we've got to think about is the environment that we live in. So if you live in a population where when they present to you, they're already above the threshold, so the prevalence is high, you're going to be wanting to do things to convince yourself that you don't need to do anything for that child. So, but we live in an environment where our prevalence is low, as I've already said. So we're either going to be investigating to get our prevalence lower than our 0.5%, or we're going to be looking for things that push our prevalence up to push us above our threshold. Now, some research has been done on this. It's all retrospective and it's not high quality. But Van Broel, and there's a paper that's been the systematic review of all trials that looked at this, where they looked at some historical features and examination features that might help us to see whether our threshold was raised or decreased by features. And what they came up with, I think, is a helpful list, but it's not entirely helpful because some of the things they talk about are quite vague. So they talk about parental concern. Now, what parent is not concerned if they're bringing their child to an emergency department? But the way I think of that is the ongoing concern, despite what you might be able to reassure them of. We talk about this clinician instinct that I've already alluded to. They talk about changed crying patterns. So these are all objective measures from the research, from the literature. A child being drowsy, a child moaning or inconsolable. And then we can look at examination findings, so cyanosis, poor circulation, including tachycardia and poor perfusion, respiratory signs. Interestingly, a temperature greater than 40, which used to be the old pre-pneumococcal vaccination test for whether your threshold went up to 5%, which was the old threshold for when we used to treat. So when I was a resident in paediatrics, pre-pneumococcal vaccination, we used to say fever without source. If you're worried, do a white cell count. If the white cell count's more than 15,000, then maybe treat empirically. So what a white cell count in those days of more than 15,000 meant was it took your risk of occult pneumococcal bacteremia, which is not sepsis, from 4 to 8%. So in those days we said, if there's an 8% chance that this child has occult pneumococcal bacteremia, then I'm going to treat empirically with antibiotics. And a temperature of above 40 takes your chance of having a serious bacterial infection up to about 5%. Now that might be a urinary tract infection or pneumonia which doesn't need IV antibiotics, but I found that interesting. So we can sort of put down a list of things that will help our gestalt, that we can just go, do any of these factors apply? So is the parent still worried despite the fact that I've told them, it's probably a virus? Am I worried? Am I worried about them? Do they just look unwell? So are they poorly perfused? Are they not interacting as I'd expect? For me, it's heart rate, so tachycardia. In the case I talked to you about, the thing that made me put a cannula in that child was the persistent tachycardia. Changed crying patterns, petechial rash, loss of consciousness. So that some of those are obvious, some of them are a bit vague. So then we get to a point where we want to do an investigation. And we wanted to either do an investigation because our threshold's gone up and we want to bring it back down to really convince ourselves, or we want to see if this child that we're sort of vaguely worried about pushes above a threshold. And we throw around terms like sensitivity, specificity, positive predictive and negative predictive value, and I always have to look them up. Like when I'm teaching this, I unashamedly pull out my iPhone and go, I've got no idea what it is. Let me look at my picture first and then I'll draw it on the board for you and explain it to you. But what we're really interested in is positive predictive value and negative predictive value because they reflect the prevalence of the disease. And that's our challenge, a low prevalence disease, so what's going to push us above threshold. So CRP is an often used test, and without going through the maths, if you start with a CRP, with a prevalence of 1%, so if the child in front of you you think has a 1% chance of having sepsis, and you do a CRP on them and it is above 40, then from the best evidence that we have available, again, which is retrospective and based on poor definitions, your chance that that child has sepsis probably goes up to about 4%. I have seen many children with CRPs of greater than 40 that I've sent home and told that they don't have sepsis and they've probably got a viral infection. But that's the number. And if your prevalence is a lot lower, which ours probably is, then you don't get as high a positive predictive value. Negative predictive value of these tests is not as useful because if we say 0.5% is already our prevalence, we've already got a negative predictive value of 99.5% for the child sitting in front of us, so we're not really going to improve on that much more. So that brings us to the bane of many paediatricians' lives, and I say that as someone who works in emergency, and that's the pediatric sepsis pathway. So this is the New South Wales pediatric sepsis pathway, but there are a number of them around. And I think the trouble with this is that people feel like too many kids are triggering this pathway, and I'm having to receive calls about children who emergency departments have given antibiotics to, and I'm having to deal with all these children who have triggered the sepsis pathway. But if we go back to our threshold, if we're saying that 5%, everyone had their hand up at 5%, well, that means, and just because I'm a bit stressed, my maths is letting me down, but I think that means 1 in 20. So what we're saying is, if even at 5%, well, 20 children have to activate this for 5 who are going to have sepsis. So you're going to be still going to be getting a lot of calls for children who probably have the virus. But I think it's a useful, almost like a checklist to go through of signs and symptoms. So this is the New South Wales one, and it's based on a recognition part and then a respond and escalate part. But you have to have a historical concern, and you also have to have abnormal observations. I can tell you from practice that in my emergency department, when this is activated, which is not very often anymore because we tend not to use it, I'm being serious, the most common thing I would do is take a child off the sepsis pathway and say they've got tonsillitis, it's probably a virus. So that's the challenge of recognition, and maybe we just need to be a bit more objective in the signs that we're looking for and actively think about our thresholds and think, rather than saying this child doesn't have sepsis, saying this child has a very low chance and it's maybe about 0.5%. And then there's a role for observation and seeing if that threshold changes over a period of observation. Very quickly, just going to talk about treatment. So there are 3 big adult trials that many people will be familiar with that look at goal-directed therapy in sepsis. None of these applied to children. And realistically, we're not going to get big trials in children that tell us what to do in terms of the management of paediatric sepsis, and a lot of the practice is going to be extrapolated from adults with a knowledge of paediatric physiology to moderate some of those results. And they essentially showed what we already do in paediatrics, which is not do goal-directed therapy for sepsis. So and this is the treatment arm, we give antibiotics and fluids. One tension is early antibiotics before getting specimens. So, you get a call, the call from emergency where we're worried about this child. We've given them intramuscular ceftriaxone because it's going to take a while to get access and we haven't got any specimens. There's some low-level retrospective evidence that you've got up to 3 hours to give antibiotics. So one paper, which was a retrospective study of a couple of 100 children, showed poor outcomes only after 3 hours. So I guess if you've got a child who's acutely and obviously unwell and septic, the priority is antibiotics. If you've got a febrile child that you think's a bit unwell, there is probably time to get some access and get specimens off before giving antibiotics. The final thing I wanted to talk about was, we've talked about antibiotics being our saviour. So this is, I don't know if any of you have heard about Apocalypse Pig. So this was a couple of years ago. And Apocalypse Pig refers to the colistin, which is an antibiotic used extensively in the agricultural industry. And it's a fairly narrow spectrum of action antibiotic, but it was the last antibiotic that did not have a resistance mechanism described. Colistin now has a resistance mechanism described in animals and also in humans. So we might be living in a golden age of sepsis where we struggle to diagnose it, but we know that through vaccination it's very rare. It's still tragic when a child dies of sepsis, but we don't see it that often. And when they do have it, we can mostly treat them with antibiotics, but we might soon go to an era where we don't have the breadth of antibiotics that we have now to be able to treat sepsis, and we might see more severe and bad outcomes from sepsis. I don't think that means we shouldn't use them in our acute environments, because I think the bigger drivers to antibiotic resistance are more chronic use and use in the agricultural industry. So I just wanted to leave you with that message about sepsis is hard to recognise, but there are some objective measures you can use to define your gestalt, and really to just think about your thresholds and trying to put numbers and chances on what is often quite a nebulous predictive value that you've got of how likely this child in front of you is to have sepsis. Thanks.